Hey everyone, and welcome back to the Complete Dentures 1 course at New York City College of Technology, Department of Restorative Dentistry. This is Module 10. In Module 10, we will cover a little bit about the lower anterior setup and some different types of occlusal schemes. Let's begin. To begin, when we talk about the position of the mandibular anterior teeth, let's first talk about the central. The labial-lingual inclination is slightly depressed at the neck. The mesial distal inclination is perpendicular to the occlusal plane, and the arch alignment is on the curve of the arch of the occlusion rim. Chances are, if you set teeth by maxillary 6 anterior first, and then the maxillary posterior, and then move down to the mandibular posterior, the lower anterior are going to be your last teeth that you set. Usually these fit perfectly within the space provided, as long as the teeth are set correctly in a proper cusp to fossa relationship. Most denture teeth are made to be in a 1-to-1 relationship. That means 1 millimeter of overjet and 1 millimeter of overbite. With that kind of relationship, you should end up with your lower anteriors fitting within that space. Back to the mandibular anterior tooth setup, we have our lateral. The labial-lingual inclination is perpendicular to the occlusal plane. The mesial distal inclination is a slight distal inclination, and the arch alignment once again should follow the rim or the overall arch form that you've created on your maxillary if the lower anterior teeth are the last set of teeth that you are setting. The canine. The labial-lingual inclination is inclined. The mesial distal inclination is more distally inclined than the lateral. In the arch alignment, the mesial half of the labial face conforms to the curve of the arch initiated by the incisors. The distal half of the labial surface is angled to match the posterior buccal alignment. This is basically the same exact concept when it comes to the maxillary canine. The mesial plane is in alignment with the anterior arch form, and the canine distal plane lines up with the posterior teeth. That basically is why they call it the corner tooth of the mouth, because that's the tooth that makes most of the turn of the arch form. Now, as I discussed previously, overjet and overbite, if we go into those terms, overjet, a good way to remember that, one of my professors taught me that overjet can be remembered as if a jet flies horizontally across the sky, overjet is a horizontal space, right? Although that doesn't necessarily make sense when you think how a jet flies, right? It flies up vertical or horizontal, but overall, from one point to another, flies horizontal. So overjet, it's a good way to remember it. And overbite. Overbite is your overlap, right? How much does your maxillary incisal edge cover your mandibular incisal edge, right? That distance is your overbite. So horizontal overlap. Between 1 to 2 millimeters of horizontal overlap is an acceptable range in all cases where the ridges are normally related in a Class 1 occlusion. Class 2 occlusion, or Class 2 ridge relations, require more than a 2 millimeter horizontal overlap. If you recall, Class 2 means that you have a retrognathic bite. Your lower jaw is protruded back in association to your maxillary. The incisors are edge to edge in a Class 3 ridge relationship. So usually incisal edge to incisal edge, although a underbite can exist in patients that are severe Class 3. Also, Class 3s are very synonymous with crossbites. We have a vertical overlap. The amount of vertical overlap can be expected to change directly with increases and or decreases in posterior cusp height. The 30-degree posteriors can generate as much as a 2 millimeter vertical overlap between the upper and lower anterior teeth. When 20-degree posteriors are used, the amount of vertical overlap required might be only 1 millimeter. The rule of thumb is, since horizontal overlap is more or less standard for normal ridge relations, which is 1 to 2 millimeters, use enough vertical overlap to make the anterior teeth balance in working and protrusive contact relations. We're going to get a little more into that this lecture, talking about working and balancing contacts as well as protrusive contacts. Here is a shot of what that might look like. Once again, if you set your maxillary teeth first and then go straight to your mandibular posterior teeth, the last teeth you will set are your lower anteriors. And this is what that might look like. These illustrations are directly from the Air Force Manual. Now, talking about a compensating curve and balanced occlusion, what do these two things have in common? Well, compensating curve, as you may know, should have been covered in multiple courses within the semester. But when we talk about a compensating curve, that is a curve made up of two separate curves, right? We have a curve of Spee and a curve of Wilson. So let's get into these curves. According to the 4th edition of terms in your Air Force Manual, in reference to curves and balanced occlusion, balance is the simultaneous contacting of the maxillary and mandibular teeth on the right and left in the posterior and anterior occlusal areas in centric and eccentric positions. Eccentric meaning any position out of centric occlusion. So it's developed to lessen or limit a tipping or rotating of the denture bases in relationship to the supporting structures. In simpler language, just about all the teeth are supposed to be able to contact everywhere in centric and non-centric positions. In order to achieve this elusive ideal, dentures must be fabricated with a compensating curve. The compensating curve is necessary in order to achieve a bilaterally balanced occlusion. That's basically what that paragraph is trying to tell you. So a compensating curve is an alignment of occluding surfaces and incisal edges along definite anterior, posterior, and lateral curvatures for purposes of developing completely balanced dentures. So the lateral component of the compensating curve is the curve of Wilson. That means your smile line, right? When you think about how someone smiles, the left to right portion of that curve, as you see in the illustration above to the right, is your curve of Wilson, right? You know, smile ear to ear, right? Curves upward. That's your curve of Wilson. It's a lateral curve when you're looking straight on facially at someone, right? And then we have our anterior posterior curve, which is from the front to the back, and you can see it kind of swoops up towards the posterior and dips in the middle. That is your anterior posterior curve. That's called your curve of Spee. Now, in practice, the place where the compensating curve begins varies for each dentist's personal denture philosophy. It also varies with the kind of posterior denture tooth that's being used. For example, the curve used with one manufacturer's teeth starts at the first premolar region. A curve appropriate for a different tooth form begins in the first molar area. When in doubt, just read the directions. It really does have to do with different tooth molds. I would say that curve can occur anywhere along the posterior. Some are more exaggerated than others as well. But overall, the compensating curve is important when it comes to a bilaterally balanced occlusion with complete dentures. Another term that's important when it comes to complete denture work is the Christensen's phenomenon. So what is this Christensen's phenomenon? It's defined as the space that occurs between opposing occlusal surfaces during mandibular protrusion. That's when your lower jaw moves forward. The anterior teeth are responsible for the disclusion of the posterior teeth during the protrusive movement. So what you see here is the lower teeth in centric occlusion in figure A. When the lower jaw moves forward in figure B, posteriorly, your back teeth should disocclude, right? And that's a natural dentition, right? In natural dentition, a lot of times when you move your lower jaw forward, your back teeth do not touch anymore, right? When you have the curve, the compensating curve, it allows you to maintain contact everywhere, right? We just spoke about how balanced occlusion requires contact everywhere in centric and eccentric positions, meaning during movement, right? So when we look at this compensating curve, we see that in illustration C, the lower anteriors have moved forward, yet there's still contact in the posterior, and that is because of that figure you see there with the line. That is your compensating curve. That curve allows for contact everywhere, allowing for the bilateral balanced occlusion that we're looking for within this semester in your laboratory projects. Now, the concept of why this does not usually exist in natural dentition is what we call mutually protected occlusion. In natural dentition, when you think about how your teeth sit into your periodontal ligament and in your alveolar ridge, we think about the root forms, right? So to put it quite simply, when you think about an anterior tooth, it usually has the longest roots, right? Now, why is that? When I make the analogy of if I were to take a pencil and stick it into cement, right? And stick it all the way down to the eraser. Let the cement set and then pull on the pencil. It'd be very difficult for me to break that pencil in a lateral direction, right? Now, if I only put the first quarter of the pencil into the cement, let it set, and then pull on it, the pencil will usually fracture, right? Well, that's the kind of concept of why anterior teeth have such long roots, right? They're meant to take lateral forces, right? And when you go into those lateral excursions, you have protrusive guidance, right? This Christensen's phenomenon where your posterior teeth disocclude. That's because they're protecting your posterior teeth against lateral forces because they're meant to take that force, right? And same thing as when your jaw slides into right and left excursions with natural dentition, you're usually looking for a canine guidance, right? The canines touch, everything else discludes. Now, why does that happen? Once again, the canines have a very long root form, and they're able to withstand the lateral forces. Vice versa, when we talk about posterior teeth, a lot of the times there's an ever so slight space between your lower anterior teeth and your maxillary anterior teeth. And when you chomp down on your occlusal surfaces in your posterior, your occlusal teeth, your posterior teeth have an occlusal table, right? The table is wider than an incisal edge. That table is wide and meant to take vertical forces. So as you chomp very hard on your teeth, your posterior teeth distribute the forces along that occlusal table, while your anterior teeth are now protected. So you see now why it's called mutually protected occlusion. Anterior teeth protect posterior teeth from lateral forces, and posterior teeth protect anterior teeth from vertical forces. So just a thought to have when it comes to denture work, how we aren't looking to disocclude areas when it comes to denture work. We're looking for bilateral balanced occlusion. We want contact everywhere during function in order to avoid the tipping of a denture or the popping out of a denture during function. Okay. So one major reason a compensating curve is necessary in the presence of the Christensen's phenomenon is that this phenomenon, the condyles leave their fossa, move down the eminences until the incisors are edge to edge. If the compensating curve in a denture is shallow or not even there, the descent of the condyles down the articular eminence shows up as a gap between the posterior teeth. The space is smallest anterior and becomes progressively greater towards the posterior, as you see in figure B. And once again, we're looking for contact. So the compensating curve is necessary because of the Christensen's phenomenon. Since on the topic of balanced occlusions, let's talk a little bit about working and balancing sides. So a completely balanced denture can be made with using teeth with almost any cusp angle from 0 through 33-degree teeth. However, most balanced complete dentures are made with cusp teeth. When it comes to anterior teeth, the centric occlusion, there's about 1 millimeter of vertical and horizontal overlap between the maxillary and mandibular anterior teeth. Now, when talking about working and balancing, let's talk a little bit about the illustrations we see. In the illustrations, you see an arrow where it says the upper member movement. That is referring to the articulator. Obviously, the upper member does not have movement in reference to the intraoral environment. The lower jaw is the one that moves. So although here we see the upper member moving, it is important to remember that the lower jaw is the one that moves in the mouth. So in this illustration, if we are viewing this as this is a cross section of posterior teeth. Let's say these were posterior teeth that you were looking at on an articulator that you were setting. So the articulator is facing you. When the articulator is facing you and you take your upper member and push it towards the right, that is simulating a patient's lower jaw movement towards the right. Whatever side the lower jaw is moving towards is considered to be your working side. The contralateral side, the other side, is considered to be your balancing side. So once again, if my lower jaw is moving towards the right side is my working side, and the left side would be considered my balancing side. Now, when we talk about the working side, the maxillary and mandibular anterior teeth on the working side contact each other. The posterior teeth exhibit what's called cross-tooth balance, which means the lingual inclines of the maxillary buccal cusps, right? And you can see that in the illustration on the working side circled, right? The lingual inclines on the inside of the maxillary buccal cusps are in contact with the buccal inclines of the mandibular buccal cusps. So we look at our mandibular buccal cusps and we see that that buccal portion of the buccal cusp is in contact with the lingual incline of the maxillary buccal cusp there, right? So when we look at our lingual inclines of the maxillary lingual cusps, they are in contact with the buccal inclines of the mandibular lingual cusps. So we see that the working has contacts on all cusps there, and then when we reference our balancing side, on the balancing side, the buccal inclines of the maxillary lingual cusps are in even contact with the lingual inclines of the mandibular buccal cusps, and there's no contact between the upper and lower anteriors, right? So when it's balancing, you have lingual cusps of the maxillary touching buccal cusps of the mandibular, okay? So this may seem a little confusing. It will be much easier to understand this when viewing teeth in motion on your articulator while you're setting your teeth. And here's a little idea about group function. Group function is technically a term used within natural dentition or RPDs. However, I like to use this term with denture work because it gives kind of an overall concept of how these teeth should be working. And the truth is that, yeah, they should be working in groups and in function. So I like to call this group function just because if you have a fully balanced denture, all these teeth should be working together in a group, right? So we see our regular centric on our top image. On our bottom right, that is our working side. On the right side, when the lower jaw is moving towards the right, you can see that we have multiple buccal cusps touching during that excursion. There is no canine guidance going on here. As we spoke about before, we want multiple teeth touching at all times, working and balancing. And on the image to the bottom right, you can see that also when going into the left excursion, left working side, multiple teeth touching during the excursion and no discluding of any teeth, okay? So balanced dentures overall, advantages and disadvantages. Some advantages can be that cusp teeth look more natural than 0-degree teeth, and that is true. 0-degree teeth are very flat. They tend to be the band-aid for denture mills. Denture laboratories that are into large production scales will set in 0-degree. Some dentists consider to set in 0-degree. It is the easiest form of setting teeth. However, we're meant to have cusp tips, right? So in my opinion, if we were meant to have flat teeth, we would chew on things that cows would eat, right? Cows kind of grind their food, not necessarily chew it. The fact that our natural dentition has cusps on it, the goal is to really restore what's missing, in my opinion. Cusp teeth seem to break up the food better than non-anatomical teeth. I guess this is pretty obvious given that these posterior teeth that are anatomical have cusp tips, right? They can shear food. Balanced dentures are somewhat resistant to tipping forces. When a denture tips, one end pops up while the other stays down. Now, the reason why it says somewhat resists the tipping force, because at the end of the day, I always say that a denture is a denture. No matter how well the denture is made, there are still removable prosthetics that sit in an intraoral environment. Some patients have really good retention due to their bone, due to their oral anatomy. Sometimes the overall shape of the residual ridges can aid in the retention of the dentures. And some patients are less fortunate where no matter how well the denture is made, if they don't have the proper oral anatomy, the dentures will always be loose. So it is kind of difficult to say that a certain type of occlusion will eliminate all tipping issues that can occur with dentures, but balanced dentures do somewhat resist the tipping forces if done correctly. Now, the disadvantages. Balanced dentures are definitely the most difficult to set. It takes a lot of practice and time and knowledge base to be able to set this kind of occlusion and for it to work well intraorally in the mouth. Completely balanced dentures work well for patients with good ridges, but are not as effective for patients with poor ridges. Cusp teeth set for balance are expected to mesh well in centric occlusion. If a patient's ridge height is insufficient to support the balanced denture, lateral movements with the mandibular will cause the lower denture to dislodge or stay behind, or the upper denture to lose its seal and travel with the lateral moving denture. So if there is not enough support for these cusp teeth, yes, it can cause extra movement unwanted movement of the denture. Precise records are required to accurately reproduce the mandible's movements on the articulator, which is very true. We talked about maxillomandibular relationships, our centric bite, centric relation. We have our lateral, left lateral bite, right lateral bite, protrusive bite. All these records really need to be used with at least a semi-adjustable articulator in order for you to truly create a bilaterally balanced or completely balanced occlusion for dentures. With balanced dentures and cusp teeth, there is an increase in lateral forces, which can be detrimental to the residual ridges. Concept of if the denture moves more than it should, the constant rubbing of the denture on these anatomical areas can actually cause bone or tissue resorption. So we really don't want a denture that rubs constantly, not to mention sores. So if you're going to set a bilaterally balanced denture, you really do have to understand the concepts and theories behind it so that it's done correctly and doesn't cause more harm than good. So very briefly talk about two of the most common types of other occlusions. Lingualized seems to be very popular nowadays, and we'll also talk about monoplane in a second. Lingualized occlusion, to put it briefly, is basically most of the time using a cusped or degreed maxillary posterior tooth, about at least 20 degrees, with a monoplane mandibular posterior tooth. Now, basically what happens here, since you have a flat plane with a cusped tooth, now you're only talking about having, I believe it's only 12 points of posterior contact or something along those lines, rather than 24 in a bilaterally balanced occlusion with deep centric occlusion. So less contact points means less areas for things to tip out, right? But let's talk about advantages and disadvantages for a second. So advantages of lingualized occlusion. There's maximized cutting efficiency with minimal lateral forces. Once again, your posterior teeth on the mandible are monoplane. There are no cusp tips, which means that the maxillary cusp tips can glide on that flat plane without causing lateral forces to displace the denture. There are improved aesthetics over purely 0-degree posterior teeth, because at least from a smile line perspective on the maxillary, when someone smiles, they have cusped teeth in the posterior. Maxillary cusped teeth break up the food better. Lingualized occlusion has a limited amount of lateral forces due to the small area of contact between the maxillary lingual cusps and the 0-degree mandibular teeth during lateral excursions. This occlusion can be used for a wide variety of residual ridge conditions. And the main disadvantage for lingualized occlusion is that it's a compromise between using anatomic and non-anatomic posterior tooth forms. In a non-balanced setup, the denture still may tip in contact positions other than centric occlusion due to the lack of balance in contacts, all right? Since you don't have those cusp tips, it may dislodge if it's not set correctly. Very minor disadvantage. It seems that this is an occlusion that is received well by multiple different categories of patient, whether they have really good oral anatomy for a denture, or let's say they didn't have the residual ridge or bone structure to retain a denture as well. This seems to be a general occlusion that works across the board. And then we have monoplane occlusion. Quite simply, there are completely flat teeth, as you can see in the image on the bottom right. Some of the advantages to setting teeth this way are that monoplane dentures are somewhat easier to set than the completely balanced denture. They're actually probably the easiest denture to set, period. As you see, there are no cusp tips, which means that there is no real cusp to fossa relationship that needs to happen because there is no cusp or fossa to have a relationship with. They are flat teeth. So that basically means that your posterior teeth can align however you want as long as they are touching occlusal surface to occlusal surface. This makes it extremely easy to set teeth. Your anterior teeth just need to be in the proper overjet and overbite, and your posterior teeth fall where they fall. A set of monoplane dentures function well in almost all patients and is the denture occlusion of choice for patients with almost no residual ridge or poor ridges. A set of monoplane dentures minimizes lateral stresses completely because there are no cusp tips to knock into each other during lateral movement. And due to the absence of inclined planes, the ridges are subject to vertical pressures, which are considered less damaging than the lateral forces. The monoplane principle is the denture occlusion of choice for Class 2 and Class 3 jaw relationships. It is also the denture occlusion of choice for crossbite cases. I would say, in my opinion, Class 3 is probably the best to use monoplane for. The lower jaw is so protruded forward that cusp-to-fossa relationships are difficult, and sliding left and right in order to use those occlusal tables properly to eat can be difficult. So monoplane is definitely a good choice for crossbite and Class 3. I do believe that Class 2 occlusion can still be set with cusp teeth, but yes, it is an option, monoplane teeth for Class 2. Disadvantages of monoplane occlusions. The 0-degree teeth don't look natural at all. Flat teeth are not something that are natural in the mouth, so definitely a disadvantage. 0-degree teeth don't really break up food as well, right? There's no cusp tips there to kind of shear food and tear food up, so that can also be a disadvantage. And monoplane dentures have more of a tendency to tip than balanced complete dentures. In fact, the lack of protrusive balance is a special invitation to tipping. With that said, we have concluded this module's lecture. The readings are the same from last week. I had split up the lecture. I think you can see now that it was necessary. A lot of information about different occlusal schemes and bilaterally balanced or completely balanced dentures. So I wanted to make sure that I went in depth and covered the content thoroughly. You do have a final coming up, not next week. After the week after that, we will do a review, but the following, right? The 15th session is your final. And if you have any questions, please feel free to reach out. And I hope you enjoyed the lecture, and we'll be in touch soon. See you in the next module. Have a great day.